Welcome, everybody. Good evening. So, for those of you who don't know me, my name's Jermaine Revalier. I'm Provost Chancellor Academic here at BNU. So, I work really closely with our profs and our associate deans, etc., etc. And before I introduce our speaker, I just want to say some of the visitors we've got here to listen to Adetoro. We've got colleagues from as far away as Liverpool and Nigeria, as well as two of Adetoro's daughters here to listen to this talk. So this is an amazing day. So welcome, everybody, to Professor Adetoro Adegoke's inaugural professorial lecture here at BNU. Adetoro is a professor in health inequalities. She's also relatively recently become the Associate Dean for Research and Knowledge Exchange in the College of Health and Society. She's the founding director of the Center of Excellence in Health Inequalities. And that's a piece of work that not only reflects Adetoro's vision and leadership, but our wider commitment to research that's both academically excellent, but probably more importantly, impactful and transformative. I'm not sure whether I should say this next bit, but it looks like Adetoro's got over 26 years worth of experience. Sorry, Adetoro. Across healthcare delivery, higher education, international development, and has built a career defined by impact, scale, and purpose. She's conducted one of the first community-based studies investigating maternal mortality in Nigeria, led multi-country research across Africa and Asia, and her work is consistently focused on those most excluded from health systems. Adetoro has led major international programs and research across over 17 countries and has tackled some of the most complex challenges in global health. Her research has directly informed policy at national and global levels, including work with the development of the WHO's framework for action to strengthen the quality of midwifery education, a landmark contribution to global health systems strengthening. But as I've already said, what really distinguishes Professor Adegoke's work is not just the academic rigor, but its reach and its relevance. So her research is translated into real work change, into workforce strategies, training systems, health service delivery, community engagement. And she demonstrates repeatedly that meaningful and sustainable change happens not just in isolation, but through deep and meaningful partnerships with communities, practitioners, and policymakers. So her lecture this evening is titled Health Equity at Scale, From the Margins to Social Transformation. And it will invite us to think differently, to move beyond just describing an inequity towards redesigning a system that produces it, and to consider what it truly means to deliver health equity, not through isolated initiatives, but at scale, across systems, and with lasting impact. So it's my great honor, on behalf of everybody at BNU, to introduce Professor Adetoro Adegoke to deliver her inaugural lecture. And I'm going to go sit over there.
Good evening, distinguished colleagues, friends, family, and honored guests. Thank you for being here to share this important moment with me. Today, I would like to take you on a journey from the margins to the center of system transformation. This lecture is about equity, about power, and the responsibility that we all carry as leaders. I want us to begin with a truth that we all know too well. And that truth is that health is not equally distributed. And I'm sure we all agree. Despite progress that we have made nationally within the UK and internationally, globally, marginalized populations, whether marginalized by race, marginalized by gender, by poverty, by migration status, or by their location, continue to suffer avoidable health disparities. Most times we quote statistics, but this is much more than statistics. It's not about statistics. Those figures represent actual stories of injustice, of system failure, and of course, of potential of people's life cut short. Public Health England has given a definition of health inequalities, and they have described health inequalities as those systematic, avoidable, and unjust differences in health and well-being between groups of people, and sometimes even within groups of people. One of the very first frameworks on health inequalities, referred to popularly globally as the inequalities rainbow, talks about the effect and the importance of other drivers of health. Because of the definition of health inequalities, it is easy for us to think that the drivers of health inequalities would be within health. But over many years of work, over many years of evidence gathering, we know that there are a lot of determinants that actually drive health. And those determinants have been referred to as social determinants. We know the effect that lifestyle will have on health. We know the effect that social factors, socioeconomic factors will have on health. Someone that is not educated would have issues with employment, and that will affect the person's living condition and ultimately would affect the person's health. The framework was developed to show the importance of all these determinants. And the proposition is that if there are inequities in those other areas, ultimately there will be inequalities and inequities in health. To many people working in the space of reducing health inequalities, some may see it as a role, others may see it as a position. But to me, I see it as a calling. And I see it as a calling because I myself, I was born into poverty. If you remember when I was talking about the drivers of health, I talked about poverty as a determinant of health. We all know the implication of childhood poverty on lifelong conditions of health. I was born into poverty, 1 of 5 children, 3 girls and 2 boys. It is important to say that education has been identified as that important route that can lead people out of poverty. Unfortunately, during the time that I was born and my sisters, there was inequality when it comes to the girl child and their brothers. So they are not exposed to the same treatment or equal treatment in terms of access to food, access to education, and access to healthcare. So I was born in that period. And I feel so privileged because my parents, my father and mother, chose, despite the poverty, to allow their daughters to remain in school. I grew up seeing girls going to school or not going to school at all, or being withdrawn from schools when families face financial difficulties. So it is much more than a role or a position. And that is why my calling is to reduce inequities in health, in education, and in every shape or form. My education, through the help of my parents, enabled me to go for my first degree to do my nursing and midwifery. The motivation then was to provide health care, for the people of the community. But I was then retained, we call it retained in Nigeria. I was asked to remain within the university to support teaching of undergraduate students. As a graduate teaching assistant, my role involved supporting clinical teaching and supervision of students, going to placement sites to conduct teaching, to supervise them, as well as community placement sites. For community placement in Nigeria, as at then, based on the curriculum of nursing and midwifery, it's not about sending students to the communities to work in smaller health facilities. It was much more around bringing healthcare to the doorstep of people. So students were asked to go from door to door, house to house, to provide care. So they needed someone to supervise them. And I was going with them, staying in the community, and that quickly fueled my passion to support community well-being as well as community development. So not only the provision of healthcare, but supporting the community to be able to create water supply, digging boreholes and other things, and engaging with policymakers. But my path changed because I witnessed a maternal mortality on one of those postings. I was supervising a student or a group of students in the biggest maternity center in the city. And as I went into the hospital, I went straight to the labor room. I found my student that was posted to the labor room sat beside a woman who was dying. Despite all attempts to save her life, she unfortunately passed away, and that changed everything for me. I think that struck a chord in me because I myself had just recently given birth to my daughter, my first daughter. And unfortunately, I was unwell towards the end of my pregnancy. So it meant that I possibly could have been a statistic myself as die during pregnancy, childbirth, and puerperium. The diagnosis was bleeding after delivery, what midwives, doctors refer to as postpartum hemorrhage, primary postpartum hemorrhage. But I quickly uncovered a lot of issues around maternity inequities because of her death. So I was able to identify systems issues, so system issue related to the workforce in terms of the skills, and then systems issues around supplies, medicine, blood, and other things that contributed to the death of this woman. I quickly also uncovered the issues of policy. Whilst there was a woman, a midwife in the room that could actually conduct manual removal of the placenta because she had to retain placenta, that was the cause of her bleeding, the policy didn't support midwives to do that, despite the fact that they were trained to do that. So, of course, that quickly led me to start to work much more with policymakers. If you want to learn more about the contributing factors or the causes of maternal mortality in low, middle-income countries, please check this YouTube video on why did Mrs. X die. My encounter and interaction with the political system reminded me of that famous quote by someone that has been referred to as the father of pathology, and his name is Rudolf Virchow, who was asked by the government of Germany to look at the outbreak of typhus. So there was an epidemic of typhus in the country. And of course, everyone expected that Rudolf will come up with medical solutions to the epidemic. They were expecting maybe he will come up with things around, oh, we need more doctors, we need more nurses, we need more hospitals. But instead, he uncovered how all these social determinants, how poverty, how lack of employment, how poor remuneration fed into the outbreak of typhus. I'm sure we can relate to that during the outbreak of COVID-19. So it's similar story. So he recommended a social reformation across the country. People should be employed, they should be paid well, people should have access to universal education. What a way to look at medicine. He thereafter went on to define medicine as a social science and talked about the importance of politics when it comes to medicine. He also talked about the fact that as a doctor, as a nurse or a midwife, we are social beings. We can only talk about theoretical solutions. It is down to politicians to be able to actually make meaningful change in the system. And surprisingly, even many decades down the line, some of our curriculums are still lacking in this element of advocacy, in this element of empowering midwives and other health workers to be able to engage policymakers in a meaningful way to bring about changes in our healthcare system. My main goal, after I witnessed that maternal mortality or the death of the woman when I was in the labor ward, was to quickly look at what are the strategies to reduce maternity inequities. So I was thinking, oh, is it about skills? Is it about attitude? Is it about behaviors? Is it about engaging policymakers to actually look at ensuring more favorable, more friendly policies rather than policies that cannot be implemented or that are not useful even to the people of the country. That was my target. But then I realized that we didn't even have the right data for women. So we don't know the scale of what we were working with. There were no data. Being mindful that similarly to what was happening in other parts of Africa, Nigeria didn't have an adequate vital registration system. So it primarily then meant that a lot of women that were dying at home, a lot of women that were not accessing health facility for their birth, were dying, but their deaths were not recorded. And that led me to conduct the very first community-based investigation into maternal mortality in Nigeria. I'm sure you are wondering, oh, she talked about being poor. How was she then able to come to Manchester? I was very fortunate to receive scholarship from Ford Foundation International, who sponsored my master's program at Manchester University, and Manchester sponsored my PhD. So I'm very, very grateful to them. I used a methodology referred to as the sisterhood method, and it's based on the logic that sisters will know about the deaths of their sisters and will be able to provide information about the circumstance leading to the death of their sisters. Don't let me say it's not as simple as that, but that was the approach. And it led to a lot of information about the prevalence of maternal mortality, especially within the communities in the study area. These are some of the outputs of the work. I want to say that my work on maternal mortality was not simply focused on counting the number of deaths. It was mainly about understanding those systemic issues, those inequities, and the silences that allow preventable maternal deaths to persist within the communities and nationally. Beyond the output, the academic output, the impact of my work. Remember I said this was the very first time that this was done in Nigeria. So it became the go-to citation when it comes to talking about the number or the prevalence of maternal mortality in Nigeria and describing the perception and the attitude of the community toward maternal mortality. So this was widely cited, and it led to the conduct of similar studies in various parts of Nigeria and then outside of Nigeria in other African countries, especially Malawi. In terms of policy, I was asked to support the review of the UK maternal mortality confidential inquiries, which right from then identified the fact that Black women are much more likely to die. So it's not new. The data that we have now, Black women are much more likely to die during pregnancy, childbirth, and immediately after, much more than their white counterpart. My work formed the basis for discussion and policymakers' discourse around reducing maternal mortality at the very first Women Deliver Conference that was held in 2007 here in London. Of course, I became an activist. I became an advocate, championing the cause of women, not only around health, but around women economic empowerment. Some of you may be aware that I've received some awards around this area of my work in terms of creating social impact or social change. I've put some publications on the screen. Remember I said my focus was to look at strategies to reduce maternal mortality. So because of the things that I was able to see and the issues during the collection of data for the very first community-based study, I needed, I felt it was very, very critical to prioritize the strengthening of the health workforce. And with that, I started the education and training on emergency obstetric care. I was lucky to be with the University of Liverpool, the Liverpool School of Tropical Medicine at that time. So started off from Liverpool, from the UK, and this went globally. So supporting workforce development nationally as well as globally, at pre-service level as well as in-service level. For a lot of us, we know that a lot of the policy documents, excuse me, let me drink some water. A lot of the policy documents created by World Health Organization sometimes remain on their shelf for a very, very long time. So WHO had a training package for emergency obstetric care, which nobody could use, nobody could interpret. It wasn't user-friendly. So myself and my colleague at the Liverpool School of Tropical Medicine, Professor Charles Same, was able to revise that global toolkit to what we called the Life-Saving Skills Manual, and that was used to strengthen the capacity of health workers in many countries. If you ask about the highlights of my career, I think it's that last picture after the training manual. And I don't know if you can see it very well. It's about me being able to work with women in Cheshire who had a knitting club, to be able to work with them, persuade them, and they kindly and gracefully supported in our work then by knitting wombs that we're using for trainings in many countries. So I'm very, very grateful to the knitting natters in Cheshire. My work influenced global policy, and I was invited by the World Health Organization into various working groups and task forces to discuss my findings and to discuss my work in reducing maternity inequities, which was really so kind of them. So I was able to work at that space, and it was really good. Right from when the WHO had a department for making pregnancy safer. From there, the WHO was able to support my research work. A lot of this research work focused on looking at the global strategy that was introduced by the World Health Organization then to reduce maternal mortality. If you remember, MDG 5 talked about improving access to healthcare and supporting the implementation of skilled birth attendants. So with funding from the WHO, we're able to look at the implementation of this in many countries, in 9 countries in sub-Saharan Africa, and then in 4 countries in Asia, which found that for a lot of countries, they were able to implement, but there were various or varied definition of who a skilled birth attendant is. It was as basic as that. We also found that despite the fact that WHO introduced a strategy, there was no monitoring and evaluation framework to see the effectiveness of that. And I was able to support the WHO to develop an evaluation framework. I was asked by the WHO in 2018 to be part of a team of 3 consultants that led the consultation that fed into the development of the framework for action, which was WHO's effort to identify and shows the critical importance of midwives to the reduction of maternal mortality. But then much more around midwifery education as the foundation, for building the midwifery workforce. I was able to do that in the UK at Oxford University, and then in Cairns in Australia. And the other 2 members of the team were able to do that in other countries, including India. The bulk of my work fed into this framework, for which I am very, very grateful. And it was much more around my work on decolonizing the curriculum, because what I found working in various countries was much more around people importing curriculum that was not really, really based on the need of the region, people using mannequins and other training equipment that teachers and students are not familiar with and cannot use effectively. So that fed into this framework. The framework was launched in 2019 at the World Health Assembly of the WHO for global leaders, government, and policymakers. It was a privilege. I don't know if I should say the second highlight of my career when the WHO asked me in 2021 to please come and be the project coordinator for the implementation of the framework in 6 countries. I'm sure we all know that the World Health Organization only does norms and standards. So they develop protocols, they develop job aids, they develop policies, and then disseminate to countries. So the policies will then remain either at WHO country offices or remain in the ministries of health without people really implementing them. This was the very first time that WHO provided funding for the implementation of a policy in not only developing it, but for its implementation, just to show how critical the midwifery workforce is. So we implemented the project in 6 countries, and the countries are on the screen. It's looked at the enabling environment that will support quality midwifery education. Before then, if you remember, a lot of focus had been on curriculum, had been on capacity building, but at the highest level of policy making, the representation of midwifery leadership was very, very thin. For a country like the UK, we are fortunate that we have a chief midwife who is at the highest level of policy making and who is to ensure quality midwifery within the country. But for many countries, there is no chief midwife, and sometimes there will be a chief midwife who is actually not a midwife at all and doesn't know anything about midwifery. So the impact was around building leadership for midwifery, especially for quality midwifery education. A lot of my work around reducing inequities were not only around capacity strengthening, but then also strengthening the system, assessing the health facilities for the needs, for the basic needs that the health facilities need, and supporting through advocacy for those missing things to be provided at the health facility level. One of the defining features of my work has been the ability to move beyond academic publication as we know it, peer-reviewed articles that sometimes, or most times, policymakers don't actually read. It's much more around directing them into policy influence. So I wrote a lot of policy briefs and papers, a lot of technical briefs for public health practitioners, and a lot of how-to guides. So it's not only about implementing projects. For successful projects, how those projects can be replicated and scale up in the various settings. And of course, leading major programs in health as well, in health to strengthen health systems. I've been very, very lucky to work with Buckinghamshire University and to have the support of the leadership of the university to bring all this experience nationally and globally into the Center for Excellence in Health Inequalities, whose goal is to advance equity and to improve health outcomes. The link to the center's website is on the screen, and the center was launched last year with the opening address given by the Vice Chancellor, Professor Damian Page, and the keynote given by Professor Bola Owolabi, who is the National Director in the UK for reducing health inequalities, so for NHS England. So she gave the keynote address. The work of the center, SEI, is to focus on those identified marginalized groups within the UK. And the marginalized groups include people that are in deprived coastal areas, include people from the Gypsy, Roma, travelers, showmen and boaters communities, women in prison, migrant and refugee population, and the homeless, as well as ethnic minority communities. I talked about the maternity inequalities around Black women and Asian women earlier on. These are some of the projects that we're doing as a center since last year. And of course, they are tailored, targeting all those marginalized, core marginalized group. Our very first project shows a project with funding from NHS Berkshire Trust, which is to improve access of people from the Gypsy, Traveler, Roma, Botas community to healthcare, improve their experience, and improve their health outcome. I'm grateful to be working on this with Carla Hinnis, who works for NHS Berkshire, Professor Margaret Greenfield, who works with Anglia Ruskin University, as well as someone within the university, that's Esther Stubb, that works on the higher education pledge for the Gypsy and Roma community. The second project was actually from a partner. So the organization called Connection Support, and with this I want to thank very much Charmaine Taylor. Thank you so much, because this came into BNU through Charmaine's work involving engaging with the communities. And it was because, thank you, Tommy. It was because Karen Ferguson of Connection Support identified that a lot more women were coming into our center for support who were leaving the prison system and were going into commercial sex working. She wanted to know what were the drivers and also what are those issues that they have when it comes to access to healthcare. So on this project, I work with Alison Pierce, BNU, and Susan Perryman, and Nicola Malowan. I'm very grateful that that has happened, and we're working with Karen Ferguson of Connection Support. The Woman Labour Initiative, I co-lead with Liana Pasrogaki, Associate Professor, and we're working with other colleagues within BNU, Professor Sarah Williams and Dr. Liz Bridgin, as well as colleagues from outside of BNU. Diversity in higher education talks about gender equality at higher education level. This is funded by the British Council, and I'm working on this project, leading this project together with a colleague from BNU, the Dean of Students, Dr. Dion Spencer. And I've got partners all the way from Nigeria that are in the room, Professor Elizabeth Ojo, the Dean of Nursing from Abuad, and Professor Sunday Afolalu, the Director of International Linkages, all the way from Nigeria. Thank you so much for coming all the way. Apart from research, we, as a university, as a center, are working in collaboration with other universities on creating an equity tool called Impact that will ensure that we are creating, as a nation, equity in policy development, in service design, and commissioning by local authorities. This is led by the White Ribbon Alliance, UK. I've put on the screen some of the outputs that we have so far from the center. One very critical thing that the center wants to do is to support the scale-up of interventions, of initiatives that have been implemented. One thing you find is that with health inequalities, or with health generally, because of the reduced funding, there are pockets of interventions being implemented, and then once the funding ends, that will be it. The role of the center, one of the roles of the center that we want to do is to support those initiatives to be able to scale up nationally rather than to be piecemeal, not connected, or duplicating. From working in diverse settings in the UK and globally, I've learned many critical lessons. The first one is that we tend to call marginalized communities hard to reach. And I've just submitted a paper for publication on problematizing, the community and propositioning that hard to reach. Are they really hard to reach, or are they easy to ignore? Are we intentionally ignoring people that are from some groups of people or some communities? We cannot do anything to improve or reduce health inequalities if trust is not built into the system. So we need to build trust for every and any intervention that we implement when it comes to health inequalities. Because we are just building trust and because we are just starting from the bottom up, it may take time. Results may not be favorable, but we just need to keep on at it and ensuring that that is done effectively. Most times, or sometimes, we tend to problematize communities. We tend to identify or see communities as problems. But communities are not problems. In fact, within the communities, they are assets. People have lived experience. They understand the problems. And they can identify the solution and actually implement the solution. And we should not go, or we should stop going to communities with our own identified problems and solutions and expecting communities to buy into what we are bringing to them. It's very important for ownership, for sustainability, that communities identify and work through their problems. Because for most of us, and I'm sure for most of us in this room, we work on external funding. So when external funds end, what next? We require people in the communities, we require partners or partner organizations to continue with this work, even when our fund has finished. And that's why they are very, very critical to the implementation and the identification of what we do. From all this work that I've done, I am proposing that we need to transform what we do when it comes to reducing health inequalities. And I've developed a model that wants us to do things differently, because we cannot continue to do the same thing and expect a different result. We need to do things differently. We need to look at doing things to improve the structure, to ensure that we do that systematically, and to ensure that we sustain whatever intervention or initiative we develop and implement, co-creating with the community. So there are three core integrated pillars that I'm proposing. And the first one is about the reach. It talks about who are those people that get in, ensuring that we include the people that have the lived experience, ensuring that their perception are well integrated into what we implement, what we design, and what we develop. The depth is very, very important, and that is very, very critical to the quality and the scale-up of the intervention that we implement. And last but not the least is about power, distributing power, ensuring that communities have the leadership over their own health, over their own programs, over their own design, over the services that are designed, to support them. And with that, I want to close by saying that we all have responsibility when it comes to equity. And if, peradventure, we have not started, I want us to start now. I know a lot of us are already in this space. So either you're working in the space of reducing health inequalities or education inequities, please, we need to continue to ensure scaling up and sustainability. And with that, I want to say a very, very big thank you to everyone that is here today. If I start mentioning names, I won't be able to finish. So like Jamin said kindly, I've got two of my daughters here. I actually have three daughters. The last one is not here. Shalom is here, my first daughter, who is a medical doctor and works with Wolverhampton NHS Trust. Where's Shalom? Yeah, Shalom. And my second daughter is a student at Warwick University studying graduate medicine, and my last one is studying psychology in Leeds University. I pushed and pushed for her to come here. She said no. So I want to thank all collaborators. I want to thank the BNU leadership for giving me the space, the environment. One of the opportunities that I have within BNU is the fact that they support impactful research. Civic impact is very, very critical to BNU. And in fact, what you won't find in other universities in terms of creating funds to support the inclusion of the communities, people with lived experience, to shape the design of the project we now have as a university. You know that a lot of funders don't care how you came about developing, your proposal and everything. But through the public patient involvement and engagement fund, you can leverage this to actually engage the communities, people with lived experience, to shape the design of the project that you do, for which I'm very, very thankful. Thank you, Professor Damian Page, our Vice Chancellor. Thank you, Professor Jermaine Ravelia, our PVC academic, and all the other PVCs, Professor Sarah Williams and Paul Morgan. I want to thank the leadership of the College of Health and Society, Dr. Kieran O'Keefe, my colleague, Professor Will Broughton, my colleague, Carla Avery, who is the Associate Dean for Education for the college, and staff and students of the college. I am very, very grateful. I'm very grateful to my PhD students who have carried on a lot of my work, and researchers past and present, and Professor Bola Owolabi, the then director of National Health Inequalities Program. Dr. Ade Odunlade, I think I saw him somewhere in the room, the CEO of South London and Maudsley NHS Trust, Dr. Olayiwola Ajileye, who is the clinical coordinator for Birmingham and Solihull NHS Trust. Dr. Ajileye happens to be the president of my alumni association at the University of Ibadan. So he works with Birmingham NHS. Thank you so much. And then the president of my nursing college alumni association. I think I saw Ashiwaju Olubunmi Eluyera somewhere in the room. Thank you so much. Carla Hinis, colleagues at the Earth Watch Box, Terry Kana, University of Liverpool, Professor Charles Amen, Dr. Shadrach Abla, biostatistician senior lecturer at the University of Liverpool, the Institute of Population Studies. Professor Elizabeth Ojo, all the way from Nigeria, Professor Adeniran Afolalu from Nigeria as well, Dr. George Abraham, who has supported a lot of work and a lot of opportunities that we're looking at to leverage across Africa and Asia, not only in health, but also in education, and especially in research and policy. Thank you so much, George, for being here. Colleagues at the Buckinghamshire Health and Social Care Academy, and all of you, thank you so much. I really appreciate your presence. Thank you.